Welcome to MRI Online, Coronal, Anatomy, Intrinsics, the dreaded lunato-triquetral ligament. Why is it dreaded? There's some controversy about its anatomy. It's tiny. It can be hard to see. You need small fields of view. And this is the ligament where you may need to use arthrography maybe 1 out of 5 times. The lunato-triquetral ligament is perhaps best seen in the mid-coronal projection. It looks like a mustache, or the Salvador Dali mustache. It projects up into the capsular slit, which should be collapsed. So in my experience, the best sign, actually, of lunato-triquetral ligament injury is assessing the joint space. If the joint space is pristine and smooth, there's no fluid, and the capsule is collapsed, the likelihood of a lunato-triquetral ligament tear is almost 0. Now let's scroll a little bit, and we are moving towards the dorsal aspect of the LT ligament. And we said earlier that the volar aspect, which is right here, is a little bit stronger or thicker. Now that's probably true anatomically, but the more important stabilizer is still, like in the SL region, the dorsal aspect right here of the LT ligament. There have been many descriptors about the different shapes volarly or palmarly and dorsally. Throw those out. It's not worth memorizing them. Just realize that as you get more dorsal, the ligament gets more amorphous, and as you get more palmar, the ligament also gets more amorphous. There's attachments to these ligaments, as the ulnocarpal attachment. That one was volar, and this one right here, right there, is dorsal. They're a little hard to see, I admit that. I think you can see it better right here, the dorsal ulnocarpal attachment. The lunato-triquetral ligament also has another important variation that is not depicted here, and that's clefts. The clefts can be partial, or they can even bisect the entire ligament. So the ligament could look something like this. The ligament comes down, looks like a mustache, or a triangle with a little point on top. I'm going to make it a little bigger, blow it up. And it could have a partial cleft in the middle of it. I'll make the cleft yellow. Or it could have a full cleft all the way through and separate the ligament into 2 halves. Now that can be particularly confusing. But one thing that will help you, look at the joint. First of all, this cleft will be pretty symmetric. It usually won't be off eccentrically to one side or the other, and the joint will still look pristine. So when you have these clefts, which are common in the LT ligament, look at the LT interval for supportive evidence. Another potential pitfall in assessing both the SL and the LT ligaments is that they generally don't attach directly to the bone. They're attaching to cartilage. So if there's a little bit of cartilage irregularity or puffiness or swelling or synovitis, it may appear as if the ligament is attaching to a fluid-like area and not really attached, when in fact it's simply attached to a swollen structure that it's supposed to be attached to. So remember that these ligaments often do not directly attach to cortical bone. They attach to hyaline, cartilage, and capsular reflections. That's my story for the dangerous, tough to diagnose, and variably shaped lunato-triquetral ligament.